So while these guys get mic'd up, I'll do a little introduction to this next panel, which is really the final panel of the day between us and our final keynote by John Bush. And I guess I'd sort of lead off by saying, OMG, another catchphrase has been birthed, and so we're sort of obliged to do an mHealth segment here. I thought I'd lay out some personal groundwork and biases relative to this topic. The spectrum of health awareness, and we've touched on this many times today, but the spectrum of health awareness of human beings is relatively broad. At one end of the spectrum, we have, for example, the quantified self movement. Have you heard of this? This is the group of folks who are both, anal retentive zealots who subscribe to both Wired magazine and Outdoors. And they have personal trainers. They're obsessively measure every element of their own metabolism, pH, body temperature, energy expenditures, caloric intake. They're like Enigma code crackers here, right? And capturing every waking moment of the day. And if they've also bought Zeo sleep monitors, then presumably their nighttime data as well. At the other end of the extreme, and I have, let me just say, as my experience as an investor in disease management companies has exposed me to the shocking number of fragile diabetics smoking, overeating, cluelessly edging their way toward kidney failure and end-stage renal disease, sort of blissfully ignorant and indifferent to their own health. And it remains for me, in the middle of those two extremes is kind of all the rest of us, right? And we've touched on this point many times today, and I think it's a very open question for me, and I guess we dealt with it also last night at the dinner discussion. We did quite a lot of conversation here, guided by Humphrey from Verizon. It's an open question of how much behavior change we can really influence for that big group in the middle who will account for a huge amount of downstream healthcare expenditures. At the same time, everything else we do on the web is rushing to mobile, as we see everywhere else. So clearly it's going to happen. We thought pretty hard about construction of this panel, and thanks so much to Brian for coming back for a repeat performance this year. And in assembling this particular group of folks, I think we've found people like the last panel who are making real headway, making tangible results, finding real customers in this space, and hopefully we'll learn from them. So Brian.
Great. Thank you, Brandon. Gentlemen, we have a pretty tough job. We're at the end of the day. We're followed by Jonathan Bush, who always rocks the house. And then we have cocktails, which even at a health conference, it is tough to compete with alcohol. But I'm pretty optimistic because you three guys lead some very, very interesting companies right in this space. And we're talking about these things. And we love these things. These things are everywhere in this room, and we're addicted to them. And so I think that's the basis of why it's so important to discuss their impact on healthcare. I've been lucky enough, random enough, crazy enough to invest in two mobile health companies, Vocera and AwarePoint. They more focus on mobility in the hospital. I think we're going to focus most of today's discussion, maybe we'll touch on in the hospital a little bit, but really on the external world, the wide area network of mobility, if you will. So first, I'd like each of you to take 1 minute and just introduce yourself and your company and the particular emphasis on mobility in your company. So I want to start with you, Pete.
Great. I'm Peter Hudson. I'm co-founder and CEO of iTriage. iTriage is the most widely distributed mobile healthcare technology that helps both consumers solve their healthcare problems in real time and provides convenient and cost-effective access to the healthcare delivery system. And it does so within the framework of a platform, including mobile apps. We started the company about 3 years ago, and we work with now close to 20% of the healthcare delivery system in terms of hospitals, helping to facilitate convenient access to their doctors and their facilities.
Cool.
Alan Portela. I'm the CEO at Airstrip Technologies. We mobilize medical device data throughout the continuum of care. Medical devices such as defibrillators, patient monitors, EKGs, fetal surveillance. We cover about 600,000 babies every year out of the 4.5 million that are born every year, accessing primarily high-risk pregnancies. We are the only company that does medical device mobility that is Class 2 510K approved as a medical device. And I will say that we're getting the reputation now as being the company that made medical device mobility a must-have versus a nice-to-have. And the way we did this is about a year and a half ago, when we were gaining a lot of momentum, Apple had a commercial where they were displaying our waveforms on the iPad commercial. We were gaining momentum, but the business was not coming at the same level. So we started looking at the trends, the drivers in the industry, and we started looking at the challenges. On the driver's side, we knew about meaningful use and accountable care organizations. Every time we went to any healthcare organization, any provider, they will tell us, well, mobility will be the first thing we're going to implement. After we're done with our EMR or EHR, we knew that it's never going to happen. So technically, most of the money was going for meaningful use compliance and preparing for ACO reimbursement models. So those were the drivers. On the challenges, we recognized that if you look at the physicians, which are our primary audience, the primary care doctors are decreasing. Specialists are increasing around the top chronic diseases, cardiologists, endocrinologists for diabetes, neurologists for stroke, etc. And as we look at a reimbursement model going outside of the four walls of the hospital into an outcomes-based model, we knew that physicians were going to start becoming mobile professionals. They're not going to be in one location, and you need to bring the data to them rather than them to where the data is. So mobility had to become, at some point, the most important technology to be able to enable the transformation. So what we did is we say, okay, we cannot just send a message like that to the market. We need to figure out how is that we can impact meaningful use on ACO. And we looked at the 3 stages of meaningful use, and you see that there is access to clinically relevant data, analytics, and outcomes improvement. Basically, ACO is all that, but today. They said, you're going to get to outcomes improvement, you're going to pick the top 5 chronic diseases, and we're going to start reimbursing that way. And it's not just Medicare, Medicaid, it's also the insurance companies that are going to start implementing that model. So what happens is,
Alan, you're going to give the whole story away. I need you for the second question. Tell them the one killer feature that has made your product just so incredibly successful at proliferating.
So cardiology. So basically what we were able to do is look at the continuum and figure out how is that we can make an impact from the ambulance all the way to home. And that is what we started bringing to the table. And then large integrated delivery networks started coming to us, and our business grew 300% over the previous year just around chronic disease management. Sorry, I was just going too far.
We'll get back to all those points.
Anand Iyer, President and Chief Operating Officer, WellDoc. By way of background, I'm a wireless guy, 20 years of wireless, but I developed type 2 diabetes myself in 2002. So I affectionately joke that the 2 things that define me, one is good, which is wireless in my blood. One is not so good, which is too much sugar in my blood, but here we are at WellDoc. The company was actually founded back in 2005 by an endocrinologist. And when you think about it from a patient's vantage point, this is a disease that requires 24/7, 365 tracking, monitoring, action on a number of multivariate things, whether it's my blood glucose, it's my meds, it's my smoking, sleep, stress, exercise, diet, all the things that affect my diabetes wellness. At the same time, if I'm a little bit of a junkie, which I am, I take my data and I graph it and I take it into my doctor. There's only so much the doctor is going to do in a 2 or 3 minute office visit. The human eye can't do that kind of pattern recognition. So we did 3 things. We put a piece of software on a patient's cell phone, and keep in mind this is 2005 before the word app and iPhone existed in our vernacular. So smartphone, dumb phone, we could care less what phone it is. Put an application on that actually coaches the patient in real time right then and there about not just their testing, their glucose, their meds, their stress, their food, their exercise. Take all of that data, run it through an expert system in the cloud, and watch for longitudinal patterns. Why am I skipping my meds for the 3rd time in a 10-day period? Why am I always taking my Byetta but not actually recording my carbohydrates? It only works when you eat. And then, of course, the last thing is, could you take all of that observation and run it through evidence-based medicine and provide to the physician a one-page summary that says, hey, doc, here's where they were, here's where they are, here's what's changed, here's what you ought to do against evidence-based medicine. But you're the expert, you do what you think is right. When we did those three things, we saw remarkable improvements, 2-point A1C reductions, unheard of in the pharmaceutical world. The average drug produces, the top 15 drugs produce a 1-point A1C reduction in the market. We then said, let's take this, we got FDA clearance. We're the only ones who have this cell phone-based coaching clinical solution that's FDA cleared. We're now integrating into EMRs because we think this is important to integrate this real-time information and data and knowledge and action into the workflow of clinicians. And we're now in the process of actually getting reimbursement codes. So for the first time, a doctor can actually prescribe, if you would, this kind of software that would allow their patients to improve their health, save the system money, and have them remunerated as well.
Cool. That's great. Let's. I'm going to reference Humphrey's customer segmentation again. It was quite profound in that you have the quantified selfers, the very fit, tracking everything. You have the bulk of America, couch potatoes, should eat a little better, exercise a little more, sleep a little more, reduce their stress, and then you have the really sick. Let's take each of those segments and comment a little bit, but first we'll do an audience poll. Who has a fitness device, a specialized device like a Fitbit, a Zeo, a Lark? Okay, not too many. Okay, now those of you who said yes, how many actually use it after a month? A higher percentage than I would have thought. Now, who has a health or wellness app on their smartphone? And same question, are you still using it? Okay. Can one of you comment on what the impact or the opportunity is to serve that segment of the market? And are those businesses real, or are they destined to serve a very niche market? And will they ever get over the sustained engagement problem? This audience would suggest that the handful of folks that have bought them are still using them. What's been your experience or your prophecy about their ability to really help the healthcare cost equation and outcomes?
I have a little bit of data. We've studied through Flurry Analytics and other mobile analytics how many people actually retain apps in general, and the data is roughly about 4% at 6 months are retained on your phone. You run out of space, or you tire of that game or that point need that you had. What we found, fortunately, at iTriage is that between 60 and 70% of people that download our app keep it on their phone lifetime. So that's after about 2.5 years. And we've tried to figure out why. We're obviously glad that they do, but I think critical for mobile is solving real-time needs, and real-time needs that also have the ability to generate the motivating forces that people have, like fear, and so when somebody doesn't feel well, they want to have a real-time solution to what could be causing their problem and then where to go. And time and time again, people that have that experience write about it, read a review that was written about that. They want to keep that because it's kind of a data insurance policy for managing their healthcare. So I think we've been the beneficiary of that.
So your product really serves all three segments. It's there as in case of emergency, I can look at my symptoms and get some sense of what might be going on, and very importantly, find an emergency room, see the wait times, look at scores. Is that the case? You kind of span all three segments?
I'm an ER doc by training, so in the beginning we focused on emergent care, and we saw a lot of patients in the ER that probably didn't need to be there, and so we realized that urgent care business was going to grow and that we could help people use the knowledge of clinical information to make a better decision, and then real-time and local search to actually find it. After we added physicians and we added a lot more medical content like medications and PHR access and all the personalized services that we have added, now people use it in a much more frequent basis. They use it to look up medications their family members were prescribed, diseases that grandpa just heard about and they heard it on a phone call, or managing all of the symptoms that we all experience throughout our lifetime that may or may not rise to the level that we want to find a healthcare provider at that point in time. But when you do, we want to make it convenient, easy, and accessible to do that. So.
Now, when we did our prep call, you almost punched me through the phone when I uttered the D word, the diagnosis. What's the unique sort of line you need to walk in giving that information to the consumer, but not going over the line and getting into a liable area?
Well, this is the last panel today, so I'm a doc. I've been trained. I've practiced for 20 years and seen about 20,000 patients. I think there'll be a time in the future when a lot of medicine is practiced outside of the medical profession. I think it happens today. We all treat ourselves with medications. Over-the-counter medications will continue to get more and more complex and effective. People will need to, if you go to almost any other country of the world, you can treat a lot of the conditions that we have to go to the doctor to treat just by knowing what medication to walk in the pharmacy and buy. And so there's a real disparity between how we practice medicine in the U.S. and how it's practiced around the world. And if you look at the top 10 conditions that kill people, about 5 of them are treatable with medications and water. People just don't know what to use. And so having the information source to be able to navigate through that decision on a personal basis and make the most educated decision you can make, I think is where we want to sit. We don't want to tell people, we've asked you 15 questions and now we are confident that you are having that chest pain is due to a bruise and not a myocardial infarction. So organizing medical information in what we hope is a beautiful interface that allows for very easy access to information is exactly where we want to be.
And the mobile solution is what % of your business?
Right now, over 90%. So
interesting. Okay. Did I see one of you guys raised your hand that you had a device and you were in that first category of?
Well, no, I didn't. But what I wanted to make a comment. You divided the areas 3 sectors, and the healthy, the couch potatoes, and the chronically ill or the ill. And the issue here is that the first category is about 25% of the population. The remaining part is between those two. So those two, I would say 80% of the couch potatoes, they have one chronic disease. Mm-hmm. So they also belong to the other category. So when we're looking at mobile technology and looking at an outcomes-based model, those 2 categories are the ones that most of us are really tapping into. Of course, you go into the health side also. Yeah.
So Brian, just a comment too. Engagement is critical to outcomes. And then you ask the question, well, what drives engagement? And I think Peter's right, personalization. If I give a message back to a patient, it's time to take your medications, a straight reminder. If it were that simple, J&J would have sold alarm clocks with every bottle of drug 20 years ago. That's not why people aren't complying to their persistence compliance measures we see in pharma today. If I give a message to you that says, congratulations, good blood glucose reading, we've had patients tell us, if you give me one more congratulations message, I'll throw the bloody phone away. And the very next patient says, oh, no. If I have a good reading, can I have a picture of my grandchild show up on the phone? Because that's what keeps me motivated. So personalization is a key vector to success. I would assert that becomes part of the user experience. And then at that point in time, I wouldn't necessarily segment the way we segment today. Are you chronically ill? Are you predisposed? I would actually look at it differently from a psychosocial perspective that says, you either have this dimension where you're aware of or unaware of disease management best practices for your condition. And the second dimension is, are you economically able to afford it or not? And when you play that out, you think about the rickshaw driver in Mumbai who has diabetes, who doesn't have a place to sleep, but has a Nokia 6600. He's the unable guy. He can't afford a blood glucose meter because it's too expensive. And he has no idea what diabetes is. What is it? But if you tell him, hey, for you, maybe a half a bowl of rice instead of a full bowl of rice, that makes contextual sense. It's personalized to him. And then, of course, the guy who's able is the guy who has the meter and who has the BlackBerry and he's a junkie. And I think it's a different way of looking at the problem, saying, that's our trade space. And then in that trade space, mobile plays a heavy hand in all 4 quadrants because it doesn't know any socioeconomic boundaries and it doesn't know any literacy boundaries and things like that.
How personalized can you get? How personalized is your product? Because there's all sorts of dimension. There are people that respond to social cues, that just need information, that will respond to small financial incentives, that a negative inducement versus a positive reward?
Very personalized. So many of you know who Carlo Di Clemente and Prochaska are, the guys who created that trans-theoretical model of behavior change. Carlo's one of our advisors and has been with us since the beginning. You want to build these things such that they're personalized with behavior determinants inside. If a determinant for somebody is fear, oh, I don't want to take insulin. Why not? Grandma died when she took insulin. Well, did you know Grandma started insulin 7 years too late? Her heart was already, gone. That you want to attack that determinant, which is fear. Another person's determinant may be economics. Another one may be, I'm afraid to inject. How do I inject? Can I get help to inject? And so I think if you actually focus on these determinants, which is what we've done, you make this very personal, but you make it in a manner that they personalize. I don't go and assume and presuppose that somebody's going to personalize it in XYZ way. Let them do it.
And in terms of personalization through delivery channel, how much of your solution is mobile, smartphone, telephone calls, web-based, other?
No telephone calls. I guess everything is mobile. There's a web portal for the patient if they choose to, but today my web portal's on my iPhone. That's mobile too. There's a portal for the physician should they choose to go look at it, but many of them have iPads and many of them have. Guess what? That's mobile too. I think it's what I don't know, it was mentioned earlier on in the day. I can't remember who, but what we're seeing with mobility is a paradigm shift, and the paradigm shift is as follows. Yesterday, we would go to the ATM to get our cash. We would go to the doctor to get our lab results. We would go to the travel agent to get we would go to X. Today, mobility says X comes to you. It turns the paradigm around. That's what Ed Zander called seamless mobility way back when he was chairman of Motorola. That's a transformative in the numerator and also denominator, because you're not doing it with billions of dollars. Everybody already has a cell phone, right?
Yeah, the intro said, in the intro to this talk is mobility really here to stay? Interesting fact, there's 6.8 billion people in the world. 5.1 billion have a cell phone and 4.2 billion have a toothbrush. So I think it's probably here to stay. Whether or not it will work for healthcare is another question.
Well, in that case, even doctors may use them. So let's talk about the provider side of the equation, and what are the killer apps, and what are the areas that are going to take much more time to develop, where there is still resistance, where the doctor doesn't want to be too reachable or wants to be able to turn off at times. And I know probably all three of you have some direct experience in this.
Sure, thank you. So I will say if you look at the medical device mobility, that's the area where we can see a significant impact because it's not invasive to the physicians. They are looking right now at the data that they see on a patient monitor or an EKG, and they can annotate on those images, but it's not really invasive. The areas where you start seeing more resistance is when it comes to documentation, entering orders, because that impacts directly workflow, and unless you come up with a tool that really improves their workflow on a daily basis, they're not going to adopt it the same way it happens on the inpatient side with an Epic or a Cerner or a Meditech, et cetera, et cetera. The area where we're starting to see that they're opening up to is the area of alerting. So not only you're looking at an image, but now if I look at all the alerts that the patient had while they were in a telemetry unit, if I start delivering those alerts, this is something that they are ready to take on immediately because at their own time they can go back and instead of talking to the nurse inside the hospital and figuring out what the alert history was, now they can do it at their own time looking at the iPad. So definitely we are seeing a high level of adoption and utilization on the medical device side. We are, as a company, trying to commoditize the two most important data sources. We became a leader on medical device mobility. Now we're tapping into mobilizing EMRs with EMR adapters, and this is a completely new challenge that we are embarking. We just acquired a product as of yesterday that we will announce in the market in about 2 weeks. But this is a whole new area that we're going into, and it's going to be more challenging.
Can you give a figure or two of merit, a quantitative indication of usage or engagement or even ROI for the
Yeah, so So I will go back to that, the cardiology model. What we did is the first contract that we received, which, by the way, we clearly see today that the large integrated delivery networks are the visionaries of today. It's no longer the medical center, the academic medical center. They are more into the research. But when it comes to the vision of where the industry is going, our experience is that the large IDNs have to figure out how to manage patient population and how to figure out the new reimbursement model that is outcomes-based. So the IDNs that came to us, like HCA, Dignity Health, Texas Health, et cetera, what we did is we started looking at pilots and figuring out what the ROI was going to be. And we took CHF, as I mentioned before, and we looked at what happened to a patient when they were picked up by the ambulance with chest pain. And then what impact can we make on shortening the time from an event to a balloon time, which is the cath lab, opening up that artery if it was a complete blockage. And the interesting data is that the standard from the emergency department to the cath lab is 90 minutes. We were able to do it within 20 to 25 minutes, but not from the ED, but from the event when the ambulance picked up the patient. By the way, last week there was a segment on TV here in New York about a firefighter that had a heart attack, and he was able to go into the cath lab from the time the ambulance picked him up in about 20 minutes, as opposed to 2 hours that you do now. So what we saw is if you shorten the STEMI time, not only you improve the quality of the heart muscle, but also we noticed that we were able to reduce the false activation of the cath lab. Sometimes the paramedics will call the emergency department and say, well, I think this is a full STEMI. We should activate the cath lab. If it's not, then the hospital has to absorb that. What we noticed also is that as the patient was admitted in the ICU, there was a reduction of length of stay by 0.85 days, but also an increase on bed capacity. As you move the patients out of the ICU faster, that patient that was in the emergency department now has a bed to go into in the ICU in the event that there was an overflow. So that shortage of the ICU time, a lot of people are saying, how did you get to that? Well, less damage to the heart muscle, a shorter length of stay in the ICU, but better quality of life after you get discharged, prevention of readmissions within 30 days, and actually better quality overall. Then we looked at the step-down areas, and in step-down areas, we took 100 EKGs of patients that were discharged in the past without our product. We gave it to cardiologists because in the step-down area, when you get discharged, it's not the cardiologist that sees your EKG, it's the doctor on the staff. That is usually not the specialist. We took 100 EKGs, we put them on the iPad, and the cardiologists with different level of granularity, being able to look at the EKGs, determined that 7% of the patients that were already discharged had dysrhythmias that were not detected by the doctors on staff. And those patients were let go. They actually went home. So what happens is that 7% most likely is within the 30% or 25% of patients that will be readmitted within 30 days. And of course, if you look at home monitoring as you prevent readmissions, 1.1 million patients get admitted to the hospital with CHF. About 264,000 come back to the hospital within 30 days. It's an average of $750K to $1 million per hospital that is actually treating cardiac patients. So just for those patients that are getting readmitted, bringing mobility throughout the continuum has a huge ROI. We're starting to go to healthcare organizations right now and starting pilots where we say, how about if we don't charge our regular price, we go in for free, and after 12 months, we go 50-50 on what we can save you. And we're starting to look that if we do that, we're probably going to charge 4 times the price that we charge today.
That's significant impact. How many docs are using it, and how often do they use it?
Well, on each of the sites that we installed, we probably have about 85 to 90% utilization, depending on the facility. But if you look at an average facility of 300 beds, we probably have about 80 doctors that are using the system.
80 times how many?
Well, right now, we probably have, just on cardiology that we introduced last year, about 250 sites.
And is this something every day, multiple times a day, once in a while?
Every time a patient comes into the hospital from an ambulance with a chest pain, definitely it's what they use.
Great. Thank you. Thanks for all the good detail. And now, what's been your experience on the provider side?
I think a couple of things. So first of all, today the average primary care doc who treats diabetes, which is the first line of diabetes care in this country, because there aren't enough endocrinologists and certified diabetes educators, gets about 6 to 8 hours of training in med school about diabetes management. They don't teach them about all the other stuff that they need to know about lifestyle management because they're not remunerated to teach a patient on how to manage their lifestyle. They wait on average 12 to 14 months with the patient before they add a second drug agent, oral or insulin, or titrate an existing medication. For insulin, the statistics are even worse. They wait on average 4 to 6 years before they initiate insulin for a patient's regimen. Now, there's no blame here. It's a dangerous drug to administer. Patients may not be ready for it. And so doctors are reticent. I don't want to put this patient on insulin because they don't have the means and to manage it. And of course, in that 4 to 6 years, neuropathy, retinopathy, kidney damage, all that stuff is settling in. In our clinical studies, doctors who actually got that third piece of clinical decision support that said, here's what you should do and blah, 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 they were 5 times more likely to make a medication change or titrate a medication. And so when you think about that in terms of prescribing behavior movement, that's huge, because we were scared, the honest truth. Are we stepping on their toes? Are we crossing a line we ought not to cross? And they said, are you kidding, guys? They bring in this chicken scratch of notes that have coffee stains and they have numbers, or they bring in their meter and they download the meter in my office, but it's the flashing 12 VCR syndrome. I don't know what time sync was what. I don't know what this data means. Was it before lunch? Was it after lunch? I don't know, because I don't trust the times. The time stamping comes for free in the cellular network, which is a cool thing. So when I look at this, go back to this question about cellular, and I think about adoption by physicians. I also look at statistics, and for example, a program we did with George Washington University Hospital, where we cut down hospitalizations over a year's period by 81%. And and this was in the Medicaid population, a third of whom were homeless. Funny statistics, of that third of who were homeless, 7 out of 10 had smartphones. Forget about just a regular phone. I'm like,
where do they recharge their phone?
Yeah, well, they go to Washington. You got all these places you can plug in the city and you recharge your phone. But I mean, it's pretty amazing when you talk about ROI and you talk about how these people are adopting it. Our mantra is very simple. Doctors are no different than patients. Let them use this solution the way they want to. Some doctors have said, I don't want to have anything to do with it. My patient's doing good, great. Some have said, look, send me a fax once every 3 months, the day before they come in, and put it on the front of the patient chart so that it just fits into my regular workflow. And some doctors have said, look, I have this patient, I've known them for 30 years, I'm changing their medication. I'd like to track them in the next 48 hours. Can I get the application on my phone so I can follow how they're doing? There were some altruistic reasons you guys went into medicine, right? Because you care about patients. We see all three. That full spectrum is a good trade space.
So you guys have each made a very compelling case that there's real ROI from the mobility aspect of your solutions. What's some of the friction to mobilizing one solution? Whether are there extra HIPAA, issues around mobility? Alan, you went and actually got 510K approval, right? You had to go through that hurdle. This was considered a medical device in doing what you were doing. Can you address the hurdles that are unique to mobility, others that I haven't mentioned?
Yes, so I'll start. We had to do the same thing. We had to get our 510Ks. When we went to the FDA in 2010, they didn't have a mobile health team. They had no idea what to do with us. Are you a phone? Are you a software? Are you a blood glucose? What the hell are you? We don't know. Well, you know what? Let's meet and let's talk about what you guys are. Long story short, a year later, we got our first 510K clearance. The last one we just got for Android-based solution was 23 days. So kudos to the FDA because they're catching up. They're hiring the right people. They're bringing the right people on board. And yes, this movement of mHealth is moving faster than they can comprehend, but they're trying their best to catch up.
They have more phones than toothbrushes, too, it turns out.
I think it was toothbrushes and clean water was the other statistic, right?
Yeah. What was your story? You did it early.
Yes, and similar story. What happens is that we recognize when we were going in the area of medical device mobility that you have 3 ways of approaching mobility of medical devices. The first one is Citrix-based, which is kind of like a thin client solution. Then you look at a web-based solution or looking at a native application. And what we decided to do is we recognize that we needed to download an app and then only send parameters back and forth, but minimize the amount of data that you will transfer for any transaction. So we went native. A lot of people, when they go in mobility for other applications, they do web-based. But if you start transferring images, the amount of data that goes back and forth it's really significant, and it starts creating a degradation on the response time. And the FDA, of course, they don't look well at the Citrix solution. Web-based is what they are analyzing right now, but they're starting to have a lot of issues with the response time. Native, like them, we were the first ones really working with them, but we had situations when we were looking at the EKG. For the last 20 years, physicians have been looking at EKGs kind of like on a printout or a PDF. The fact that now you could zoom in into a lead and look at a level of granularity that you didn't see before, when we took that to the FDA, they saw that we were losing the medical aspect ratio as you were zooming in. And we actually had to go to Apple and work with them to modify the iOS to be able to keep the medical aspect ratio, the right algorithms. We were the first ones again, so Apple was open to that. If you go there today, it's much harder.
Won't get out of the lobby.
But the FDA, we partner with them, and we both learn a lot of valuable lessons. When it comes to also compliance with other regulations, the previous panel was talking about security, and the moderator talked about the fact that in banking things are done in a different way. The reason that they're done differently is because you encrypt the data at the server side, the client side, the transmission using FIPS 140-2, and then you use a dual authentication, changing the passwords every 45 seconds. Today, that is not something that the FCC is enforcing. They're looking at OpenSSL, and as care moves outside of the four walls of the hospital, they will have to start looking more and more into secure platforms that give you that type of security, like what the DoD is using. Not so much the VA. I don't know if Peter is still here. The VA is a little bit more relaxed on security than the DoD.
Pete, you didn't have the FDA to contend with, did you? What unique things did you face on the consumer side of your business?
You know, I think probably our biggest challenge was trying to distill all of the stuff we wanted to do down to a user interface that could be used and understood by a healthcare consumer. You have limited space to work with. We were always trying to build new applications before the iOS or the Android system would even allow that functionality. I think it took us 6 months to get our first app out because we had to wait until the devices could actually manage the amount of data that we had native to the phone. You know, some of the other challenges were just coming to market with different types of technologies and products. So we sell to providers to help providers find new patients or connect with their patients and make healthcare more convenient. As Mark Bertolini, Aetna, now our parent company, as of last fall, says the new quality is convenience for healthcare, at least for a big segment of the population. And so educating providers that notifying the ER before you got there could provide value, appointment setting through your phone, accessing PHRs, things like that, were just new concepts.
And how did you overcome the distribution challenge that you were one of hundreds, if not thousands today, probably 10,000 apps in the health and wellness category? And how much came from providers telling their patients versus just people found it in the iTunes store and said, this looks cool, downloaded it and started using it?
Well, we learned a lot of lessons along the way. We thought being one of the first apps that had a very broad set of content for healthcare consumers, that we would have a Sentinel PR event. And what we learned was that there's rarely a Sentinel PR event. And then we thought that maybe we could have viral distribution of our technology. And we found out that there's rarely viral distribution. So we really have 5 marketing areas. One is our just direct B2C. If you play a bunch of games on your iPhone, you probably see iTriage ads. The second is B2B2C. So we work with all of our hospital systems and providers to help them distribute iTriage to their local markets, because If they can connect with patients in those local markets, that's really valuable to them. It's valuable to those patients. It's a community benefit, and it obviously drives users for our application. We do national PR. We do local PR on behalf of our clients, and then we do B2B marketing for our lead gen. So it's become a much more complex marketing effort than I thought initially, but it's just day in and day out blocking and tackling.
Now, you guys were early with a unique value proposition, and now the category is flooded with wellness apps and gamification of health, all this stuff. What do you think? And by the way, you had a great exit relative to the amount of capital it took to build the business, so I think everyone was happy. We'll talk maybe about why Aetna acquired it, but for now, let's talk about what do you see happens to this category of tens of thousands of apps? Are most of them never going to be real businesses? Will one very large Zynga of health and wellness emerge, or is it destined to be fragmented and they'll duke it out for table stakes?
I think what we're finding is that there's only a certain amount of inventory of new users every day in the App Store market. Mm-hmm. So we've had over 6 million downloads now, and it's going to take probably years to replicate that in the mobile space, just because there's not enough people looking. Now, if you can create awareness beyond what the App Store drives anyway, that's a whole other thing, and sky's the limit there as long as you can do it. So I think there's a lot of noise. There's a lot of great technologies. If it was easier to buy them, I'd certainly be looking. It would get us to market on certain areas, but I think it's going to be hard to differentiate. It's kind of like the 90s when barbecue.com and all these sites got funded, right? And what happened was there was a consolidation then of sort of the true businesses.
Is this going to be an area that's ripe for acquisition because everyone wants to, have an angle that is promoting wellness and these things are going to be cheap and desperate to sell? Or sounds like you're finding buyers not that, or sellers not that amenable.
It depends what your motivation. If you want distribution, or you want customers, or you want a new technology, I think there's definitely going to be interest. I think everyone has to be thinking about mobile. There's more mobile searches than there are web-based searches now. So, unless you can build something and distribute it quickly, then, find something that does close to what you're doing in the right way and try to capitalize on it.
What do the incumbents do in mobile, both on the big, legacy systems? They all seem to have some small piece that's mobile. Is this going to be a must-have in a short amount of time?
For EMRs,
sure.
And that's how I think about at least the initial your initial question. For them, it doesn't. It's interesting. We've been studying the consumer experience in relation to EMRs, and very poorly distributed access. Portals are horribly used. Not only in the insurance industry, but in the provider markets too. I don't know if they do enough that patients don't want to use them, but generally, somebody's a healthcare consumer before they're a patient. And even if they're a patient, they're still a healthcare consumer, which means they probably go to multiple hospitals. They go to multiple individual clinics, doctors, et cetera. And they're not going to buy into one portal. They're going to want something that connects to a lot of different things. So I think EMRs, as they are islands and are not interoperable and are not plugged in for their own benefits to HIEs, I think are going to struggle to engage the consumer. As you look at HIEs and location-based health plans, ACOs, things like that, I think there's more opportunity as long as you can connect to many different technologies.
Interesting. Any thoughts on that?
I think it's a combo. If I were to use me as an example, when I was diagnosed with diabetes, my doc put me on Amaryl, the first drug he put me on. Didn't put me on metformin. I don't know why, but he put me on Amaryl. And Amaryl brings you down over time. It's kind of like long-acting insulin. And you're supposed to snack. I'm not a snacker. So I'd take my Amaryl in the morning, and then by noontime, I'd feel hypoglycemic, right? So my blood glucose would be 58. And so I'd eat a chocolate bar, because I didn't know any better. And 5 minutes later, I'd still feel, so I'd eat another chocolate bar. So my practice was 58, 358, 58, 358. Blind coma. That was my daily regimen. This is way back when I was first diagnosed. And yet, my doctor, when I go get my lab results drawn, he sees an average, an A1C, which is it's a funny mathematical equation, but it's an average for all intents and purposes. And he sees a number of 7.1%, and he says, you're doing okay. Come back and see me in 3 months. But he has no idea that my average is averaging from these extremes. So what we have in EMRs, which is, say quarterly data, it's reasonably static data. It's not moving. My lipids are my lipids, okay? When you add that to the real-time data that you see from these mobile systems, now you get a much more accurate picture of what's actually happening with the patient. And at that point in time, a doctor can do something. They can do something to treat. So think about this. You know that Olympic event, the biathlon, where you have the target shooting and you have the guys who have 5 bullets and skis. And so imagine the first shooter, and he shoots his 5, boom, boom, hits the bullseye in the 3rd, comes close on the 4th, and then nowhere in the 5th. And then the second guy consistently, boom, 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 upper left corner. Well, who's the better shot? It's the second guy, right? Because all you need to do is teach him how to turn a shoulder, and he hits the center every time. It's no different for a diabetes patient. If I can actually get them to reduce their scatter, if you would, and then I can treat that person. I can give them this med, that med. I can give them this exercise regimen. And so I think it's a combo of both the real-time information as well as, so the previous discussions on EMRs, I think mobile is such a logical extension because you're taking the inside out and the outside in and you're mixing them. And that gives you a very rich picture, which brings, I think, the provider and the patient closer together, which starts to affect outcomes in ways we could never have imagined 10 years ago.
Yeah, my primary care physician uses Epic MyCharts, and they have a mobile app. It's not so beautiful, but it's there. It'll probably get better. Alan, you have your company is lauded for its interface on the provider side. You said you're moving into mobile EMR. Will you open it up to consumer?
Yeah, well, so I tell you the path that we're thinking right now. So first of all, when you were talking about the big companies getting into mobility, first I want to go back to the medical device side. Philips, GE, Siemens, Dräger, all those big companies. The reality is when you start mobilizing medical devices, you need to be agnostic and you need to be able to do it inside a hospital where you have multiple systems, so you cannot just do it around your monitors. So that's one case. When you look at EMRs, EMR vendors, first, they need to figure out how to get physician adoption on their core products. And as we know, they already have a big challenge there. So looking at mobilizing an aspect that they haven't done on the desktop is going to be very hard. The way we see it at Airstrip is moving into that space. We don't want to call this mobile EMR. We want to call it EMR connector or physician companion. What we want to do is make an Epic install better by offering more capabilities, or a Cerner install better to help that CIO that made a big investment, but he's having or she's having problems with physician adoption, for us to be able to help on that. As far as the consumer, so far we want to be the silent partner of the consumer, providing data to the caregivers, but as we have this new tool, we're going to start providing some subset of the EMR connector to deal with some PHR components for the patients to be able to track the status on this system. But it's going to take us a while until we reach out to the consumer. We're going to stay with the caregiver.
Interesting. Great. Any questions? Let's open it up. Right in front.
Yeah, sure. This is a question for Anand, actually. Just a follow-up towards something that you said before about personalization. As a physician, I think that this really rings true in terms of really creating behavioral change, and that personalization is key towards a successful product. I was wondering, what specific strategies do you think are most important in terms of having what is essentially the same product, which is going to be distributed to a large number of people via App Store, web, or what have you, and how do you let the user personalize that product? Do you leverage their user input, or do you leverage the relationship between them and the physician?
Yeah, it's a very good question. I think the answer is both. So when a patient registers, for example, they put in their basic demographic information, the meds they're on, their comorbid conditions, because if I have diabetes only and I have a high blood sugar, I treat it using algorithm A. But if I have diabetes and, say, congestive heart failure as a comorbid condition, I can only drink as much water as my doctor recommended me to. So they personalize clinically, but then they personalize behaviorally. What tonality of messages do they want? How frequent do they want the message? Do they even want feedback messages? They can pick from rotating sets of messages, the rah-rah with the happy face, and or the, you know what, just give me the straight line, thank you.
Do they do this explicitly, or is the system learning based on what they respond to?
They have the option to do both. So what we do is it's like that LinkedIn model where you start them off with just basic minimum stuff. And then you invite them to come back, and the system learns more about them. And the system learns more about them. And this is where some of the expert analysis, and I did all my doctoral work in pattern recognition, so I'm a data junkie, is the honest truth. And this is the realm of clustering and not segmentation. Let me observe and let the system observe over time what outcomes are being correlated against what behaviors. And let me use that as a path to say, when the n+1th patient now registers on the system, I can ask them some Myers-Briggs-like questions. And then I can say, based on your responses, this may be the best set of features for you to start with. And then the system watches and learns, and you can adapt, and you can grow into another set of features. So it's really both. Let them use it the way they want to use it. Don't force it down their throat in any one shape or form. I think if you don't do that, you'll get some people, you'll get some outcomes, but it won't be as broadly adopted, I think.
Other questions? Yes.
iTriage. What impact, you mentioned that things had kind of leveled off after about 6 million users. What effect might it have if you had more, if you had information on there, if you could have information on there about quality, relative quality of care, and about cost?
Yeah, it hasn't leveled off, actually. We're adding 500,000 people a month right now. But in terms of the inventory of...
What was that $6 million figure you referenced?
6 million downloads.
Yeah. Sorry. And it was 6 million, but growing consistently?
Yeah.
Okay. Yeah,
we were at, 1.5 million at the beginning of the fall. So it's grown pretty quickly. So we're adding other data elements that we feel are interesting for patients. We have a partnership through Aetna with Vitals. So Mitch is here, and we have Vitals ratings on the app. And so we're starting to go into that direction. On procedures, if you look up certain procedures, we have in or out of network average cost for Aetna members. We have Healthcare Blue Book data on cost for other procedures. Obviously it's a very complex thing based on what plan you're in, where you are in your deductible, et cetera, in terms of what your out-of-pocket would be. But those data elements are obviously relevant and interesting to patients. So I think as we continue to grow our content set, those would be areas that I would imagine will grow in accuracy and in breadth across the platform.
Any other questions? Good. I was hoping you'd ask one.
Yeah.
And tell everyone who you are if they haven't.
My name's Humphrey with Verizon. So it's great to hear all things going mobile. And I think on that front, I think the question I have to all three of you and to everyone there is kind of, besides providing a network and great devices and that kind of stuff, I mean, what other stuff could we do to make lives better for you and for anyone in the room? Because I think it's one of those kind of open-ended questions here where clearly we buy devices, but we have an opportunity to influence what ends up showing up on the devices as well.
Yeah, let's do it.
I can take a shot here. And first of all, what I would like to say on mobility overall, you're going to see that what is happening in October, where we move into an outcomes-based model, is going to be very important. But also, what is happening in November, it's important, which is the elections. And I'm not going to throw a political thing here. What I'm saying here is that there's going to be attention from both parties to look at the whole issue of how to improve healthcare, how to reduce cost, improve the quality, and how to generate new jobs. In my view, mobility in healthcare is going to be the biggest, the most important technology to create jobs. Because we already talked about reducing cost, improving quality, but as we do outcomes-based and we look at outside of the four walls of the hospital, we need to start hiring case managers to be able to assist the caregivers, the physicians, to manage the patient population outside of the hospital. So definitely, the whole model is shifting, but Verizon or any of the carriers, you have a significant role. Also taking a look at cloud technology as you're doing now and figure out if you can help us with such a high reach that you have within the community to start helping us to do healthcare information exchange.
So I'll be very specific, and apologies, it's not Verizon I'll talk about, it's AT&T. They approached us a year and a half ago, at first as a self-insured employer. Said, we have 1.1 million lives that we cover and our healthcare costs are out of control and everybody in our company and our beneficiaries have a cell phone. Maybe we could use it for the 8% or odd linearity people who have diabetes. But then they asked us, well, who's doing all your hosting? Well, who's doing all of your data centers? Who's doing all of your porting from operating system to operating system and then device to device within an operating system? Who's going to do your billing? Blah, 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 all that stuff. And I'm like, you know what? We're really good at clinical algorithms and we're not good at any of that other stuff. And I'm a firm believer that 50% of a $1 billion market is always bigger than 100% of a $1 million market. So I said, okay, you know what? We could actually partner. And what's interesting is now the same model is going to be replicated elsewhere in the world, where other wireless operators have said we can also fulfill that. They have relationships, as you do, enterprise relationships with many of the people that you would want to serve, the payers, the disease management companies, the hospitals, et cetera. So I think the role of the wireless operator can be stay within your sandbox, which is what you're good at. It's how you manage data and infrastructure and all that stuff. But then getting out of the sandbox, there's value-added stuff you guys can do. There's value-added stuff you can do to help think about this. We have a prototype where I now know my blood glucose. I tested it, and it's before lunch. And my phone is a GPS phone. And my reading is 110, so it's a good reading. And so I want to know what to eat. So I have a prototype that says, here's 3 things you can eat. And now if I have GPS data, and I have the restaurant databases, which we're going to all be publishing their nutritional content in 2015 or whenever the legislation says they have to. Hey, you're a quarter block away from Panera Bread, and you're 3 blocks away from, whatever, and here's 3 things you can eat on the menu. Those are value-added services that the wireless operator brings that I would never want to do on my own. And so I think as I build this concentric circle model of what a wireless operator can do, you start at the core with what you're good at. Data, transport, infrastructure, et cetera, but then you smartly grow and you provide these things. I think there's a huge, you guys spend more CapEx than, Secretary Sebelius's budget for HIT was $19 billion. You guys spend more than $19 billion every year in CapEx. So there's a part of me that says, why aren't we leveraging that? Why aren't we leveraging this a public-private opportunity? Why do we want to go and replicate these networks when you guys already have phenomenal network capability? I think that's where an opportunity for you guys is going forward.
By the way, your 4G LTE is blazing fast. That's a big deal.
Yeah, I have one comment. You have a lot of subscribers. This is just a quick review from one of your subscribers. I was not feeling well, and then I got jaw pain. I looked the symptom up on iTriage and saw myocardial infarction. I looked at the other symptoms and called 911. Sure enough, I had a heart attack. iTriage saved my heart and my life. Thank you. So you can help get the word out about technologies that are actually making a difference every day for your subscribers and people around the world.
Okay, let's look for a last question. If not, I have one. I'd like to just hear a short answer from each of you. Other than your own company or the company of your colleagues here on the panel, name one really interesting mobile health company and what you think makes them so interesting and bound for success.
Justin Sims in Voxiva, who does text for baby, where it started in Africa that he brought here.
How's it work?
It's a maternal health application. It's a series of reminders and things for mothers who are pregnant and post their delivery.
So it pushes content at the right time?
Absolutely. And so and they followed a very similar path where they went through clinical trials and they went and just showed phenomenal reduction in infant mortality. In Africa, they're showing infant mortality reduction in South America. So they've taken a very similar path. Phenomenal respect for this company that's and using very basic technology that everybody has. So again, the numerator value proposition is huge, and the denominator cost is very, very small.
Interesting. That's cool.
Well, for us, because it is in our space, is a company, MIMS, that they do imaging also with FDA approval on CT scans, chest x-rays, and ultrasounds, and the ability to add medical device mobility with what they do. It's a very, very good synergy.
Interesting.
I guess I'd have to say lose it. You know, I think a lot of people like it. There's been a lot of benefit.
For those who may not know, what is it?
It's a weight loss application that allows you to track calories in and calories out, which is the basis of gaining or losing weight. But I'm also looking for a highly distributed or starting to get highly distributed social element in healthcare,
right?
Which I think is going to be a big challenge.
Well, great. I think all three of you made a very strong case for mobility in healthcare and its ability to actually be that real-time link when folks are actually living their lives away from their computers, whatever. And so thank you for sharing some of your insights.